Okay, so the primary mechanism for all hormonal contraception, whether it's progesterone only or progesterone plus estrogen, whether it's a pill or an IUD, anything, it's to block ovulation. And the way we do that is we take that feedback cycle where you've got the GnRH going to LH, FSH, that's going to cause ovulation. That's going to cause estrogen progesterone to be made, and those are going to come back and stop the GnRH, LH, and FSH, right? So anytime a woman's got a ton of estrogen and progesterone going, they're going to block ovulation. Why do we want to do that physiologically? When does your body have a ton of estrogen and progesterone? Pregnancy, right? So that tells you, that high level tells your body you're pregnant and shuts everything down until the pregnancy's over or until a little bit after the pregnancy's over. The reason for that is you do not want to keep ovulating while you're pregnant and then end up having successive implantations. This does occasionally happen, very, very rarely, but there are times when there are fertilized eggs that are a month or two apart from each other. But your body does not want that to happen. So it's got this set up and it's like, give me enough estrogen, progesterone, tell me I'm pregnant and I won't ovulate anymore. So all hormonal contraception acts at either increasing both or increasing progestin only. So the direct effects of EMP, we remembered estrogen grew the endometrial lining, progesterone retained the endometrial lining. Once the progesterone went away, we shed it. And EMP also affected acne and mood and migraines and all of that. So anytime we're messing with estrogen and progesterone with a contraceptive, we're changing endometrial growth, we're changing menstruation, we're changing mood, we're changing migraine, and we can be changing acne because the progesterones can also be, remember, progesterones can have some testosterone-like activity sometimes. So these are all, as Dr. Nuziali said, there's a lot of reasons you could use contraceptives that aren't just birth control. We're going to say this, you're going to walk out of here and you're going to dream of these words. Estrogen does what? Builds. Progestin does what? Retains, and a drop in progestin initiates shedding, right? So here's our combo pills and our P-only pills. So EMP combo, progesterone only. Here's your uterine cycle. Remember, day 0 was the first day of shedding of the endometrial lining, so the first day of menstruation, and then ovulation was about day 14. So with an EMP combo, what you're doing is the estrogen that you're giving with the pill is telling it to build the endometrium. So on an EMP pill, you're building endometrium. The EMP pill also has progesterone, so that's helping stabilize that out. So you build and stabilize. So you're not going to keep building for the rest of your life, right? You've got progesterone here, which has kind of an anti-proliferative effect. So by the end of the month, you've got some endometrium that's grown. Now at the end of the month, on a normal 21/7, which you'll learn what that means, pill pack, that means there's 21 days of active pill, 7 days of placebo. So what happens right here at day 21? You switched to, right, so now you have no estrogen and no progesterone anymore. And what happens to the endometrium? Sheds. So basically that combo pill is telling you, I'm going to give you estrogen to grow. I'm going to give you a placebo break so that you have a menstrual period. And we're just going to do that every month so that you get this cycle that you're used to. There are examples when you can change that because you want to alter the cycle. You can move your menstrual period back and forth. You can get rid of it by not taking the placebos. This is a neat kind of thing because since you're telling your body when or if to have a period, you can tell your body when or if to have a period. P only, you're not going to get a ton of endometrial growth. So you're kind of staying down here in endometrial growth. You've got progestin this whole time. So the growth you have it stays pretty much. And then when you get to 21, with progestin onlys, we don't take a placebo. So no placebo break means what happens? Does your progesterone drop?
No.
No. So do you get a menstrual period? No. So there's going to be little endometrial shedding. You'll hear from Dr. Nuziali that different methods in different people, some might have enough estrogen that they have spotting, like through the month, a little bit sheds here and there. Spotting, it means that you don't have a full menstrual period, but like women who have spotting might have a little bit of blood, like on their panties or on tissue paper when they go to the bathroom. That's not enough to use a tampon or be a lot, but it's just kind of like the body kind of getting rid of a little bit here and there. And you'll talk about that specifically when you're talking about how to prescribe for people who have spotting or breakthrough bleeding. So often no menstrual period occurs with the progesterone only. So remember, EMP combos, you build, and then you have a placebo that sheds, you get a menstrual period. Progesterone only, not a lot of building, and no drop in progesterone, so no one-off shedding of any of the lining that did grow. Okay, so again, I'm going to try not to be slow and repeat these too many times, but you can't leave today without knowing that the mechanism of all hormonal contraceptives is ovulation block. Whether they're a combination causing a strong feedback inhibition because they're using both progesterone and estrogen, or whether they're progestin only causing a weaker feedback inhibition because it's just progesterone. They're all blocking ovulation. Now with the combo, because you've got both of them and that feedback is very strong, you block ovulation about 99% of months. You're still going to see that 99%, I think, is perfect use, and the 92% effectiveness is going to be actual use. So again, you're not memorizing the number of pregnancies per year for these, but you know that this is going to be a much better at blocking ovulation. Progestin only as the progestin, so weaker feedback, only blocks ovulation about 60% of the time. So you're like, okay, well, that's not great. If I'm only blocking 60% of the time, that doesn't seem like awesome contraception. But it also seems to block fertilization, and it can block implantation if fertilization does occur. So that progesterone, not only 60% of the time blocking ovulation, it also changes the cervical mucus, the pH, it changes all those things that are going to keep sperm from being able to fertilize an egg. And yes, it does change the endometrial lining. So yes, there are situations in which implantation is blocked, whereas that's not the case with the combo. If someone says, I don't want any block of implantation, progestin only might not be the right thing. All right, so what do you want to know? Why are we talking about this pharmacology? You want to know for progesterone only or a combo, how is this working? Now you already know that, blocking ovulation. Is it safe to take? What do you think? Generally safe to take. When not safe to take, that you're going to be talking about. Kinetics, we want to know about kinetics because we want to know if you can miss any. We want to know ADEs, effect of the pill I'm taking right now. Can you change me to a pill with a different progestin? Can you change me to a pill with a different estrogen concentration? You want to know the pharmacology and mechanism because that tells you how to answer questions that people may have for you if they want to know how that works. And you want to know how to time the pill pack so that you know how someone is going to avoid or move their periods and how it might affect depression and migraines. So all of these things you want to know to be able to do these clinical things. Here's the progestin only effects. The progestin only, and then we're going to talk about the combo ones in a second. I like to settle these out as female cycle type effects, male type effects, and pregnancy mimicking effects. Remember, progestins can also bind to estrogen receptors and can also bind to androgen receptors. So they're the ones that have the most non-selective binding. So you're taking this progestin that is decreasing GnRH, LH, and FSH. So you're decreasing your body's production of estrogen. So you have less growth of the lining. The lining isn't shed at once, and you can have some spotting. Those are the female cycle effect that you're getting from progestin. Progestins can also have some interaction with androgen receptors. Some can be pro-androgenic, some can be anti-androgenic. I think of those as male-like effects. You can change acne, you can change body hair. And then in general, the pregnancy mimicking effects, anything that you could feel if you're pregnant might be an ADE you could have from a birth control pill. If you're telling your body you're pregnant, although at a lower concentration, you're telling your body you're pregnant, you might have pregnancy type effects. This one we looked at before when we looked at progestins. I just want you to remember that you have highly estrogenic drugs, you have highly androgenic drugs, and you have anti-androgenic drugs. Those are ones that you could be choosing what to use and what not to use based on those properties. And if I tell you one of these three, I want you to be able to tell me this information about, is it highly androgenic or highly estrogenic? Just what's here in this table. We talked about progesterone only PK. And the reason that I talked about it then, but it's going to make more sense now, is we talked about how progestin has a very short half-life. And so if you're only taking a progestin pill, it's a progestin only, no estrogen, all of its effect is going to be due to how much or progestin is in your system. And it's got a short half-life. So what does that mean? You can't miss a pill because it's not going to stick around very long. There's a lot of forms of progestin only contraception. These are the special progestins that you need to know these facts about. I may ask you a question and say, this person's on this birth control pill that has drospirenone. What's that going to do? What does drospirenone do? And you're going to be like, it's anti-androgenic. It is an anti-aldosterone. Has a longer half-life than some, but has a higher risk of clotting than other progestins. You're going to want to know from medroxyprogesterone that it actually has enough effects. Remember those non-selective effects, has enough effects at the steroid receptor for glucocorticoids that it decreases osteoblast differentiation. It can cause osteoporosis, and because of that, women have to take extra calcium. So what does a progesterone mini pill really look like? They're almost always going to be monophasic, which means they all have the same dose. You have the pill pack, all of them are the same color. There's always 28, never just 21, because you can't have a placebo. Most of them are norethindrone, which means they have a short half-life. You have to take them in a short window, no placebos, every day. There is one exception. It is only drospirenone. And if you remember, drospirenone had a long half-life for a progestin. So they picked here one that has a particularly long half-life so that you could have some missed pills. That's the only one that you'd be able to have missed pills on. Fewer side effects because you don't have the estrogen. No stroke risk because you don't have the estrogen. Not going to give you estrogen-sensitive cancer risks because you don't have estrogen. That's not saying your body doesn't ever have estrogen, but the pill doesn't have estrogen. And so you're only going to see those progestin-only side effects that we talked about here. We said those female, male, and pregnancy mimicking. Because you don't have estrogen, you're not building a lot of endometrium. Usually women don't build as much endometrium, don't have a full menstrual period, but may have spotting. But you are going to find people who have massive periods on progesterone only. I mean, some people just, their body does not like these and doesn't do what you told it to do. That's going to happen. So let's look at how these contraceptives look like when we're talking about how they're going to act in the body. I want you to be able to draw this out because when you talk about different pill types that have different numbers of placebos to them, this is going to help you figure out what's going to happen with these. So this is a 28-0, which means there's 28 active pills, 0 placebos. progesterone only oral contraceptive. This is your natural. You wanted to build estrogen, then you wanted to have progesterone maintaining, and then you wanted to have progesterone drop so that you could have a menstrual period. That's your normal cycle. So here for all 28 days, you have progesterone. So our progesterone here is a very short half-life, and you have to take it every day. What happens if you missed one pill? Your half-life is very short. So by the time you missed 1 or 2 pills, you may be down below a threshold and ovulate. So with these, everything should stay the same if you're taking it properly. Every month, all the same. But if you take one off, that's why it's such a big deal, because of those kinetics. Okay, emergency contraception. I'm just going to tell you the mechanism. Basically, contraception is contraception. It blocks fertilization. Hormonal contraception always blocks ovulation. So all emergency contraception is a high dose of a progestin to knock ovulation out of the picture, to just say luteinizing hormone, do not come. Absolutely. I don't care if it's tomorrow. I don't care if it's the next day. Do not release. Don't ovulate. Too high of a concentration to use monthly in a birth control pill, but that's why it's emergency. So you're blocking fertilization by delaying ovulation. Their progestin receptor effects can be either a progestin agonist or a SPERM, which was selective progestin receptor modulator, acting as a partial agonist, partial antagonist. But they're all acting by blocking ovulation. And there's tons of evidence that women who take these don't ovulate. And you can do ultrasounds to see if the follicles have released an egg, and they don't. So tons of evidence that that is the mechanism, and they are not abortive. What would happen if you took 3 or 4 tablets of a regular progesterone pill? It would be an emergency contraceptive. So there are no estrogen-only contraceptives. There are only estrogen plus progesterone or progesterone only. So we talked about the progestin-onlys having female cycle effects, male cycle effects, and pregnancy mimicking effects. Progestins could have all of those because they crosstalk with androgen and estrogen receptors, as well as progestin. Now you add estrogen itself. So now you're adding even more estrogen effect on top of whatever you had. So now you do have estrogen, so the endometrial lining does build. And the EMPs normally have a placebo break, so you do get a progesterone drop. So the endometrium does build and you get a progesterone drop, so the lining does shed and a menstrual period happens. So that is the big difference here in terms of what that does to your female cycle. Clot risk rises because progestins had very, very low clot risk. Estrogen does. Women in childbearing age, younger women, have a pretty low clot risk usually. So that's why these pills can work. Women younger have a pretty low cancer risk anyway. That's why these are safe. But it does rise. One of the things is estrogen is funky, and sometimes it can increase migraines, sometimes it can decrease migraines. So some women do take birth control pills just to manage migraine. The male-like effects, you have the progestin androgen type effects. Now you're adding estrogen. So you're going to have fewer male-like effects. Could still happen, depends on the progestin, but the estrogen somewhat counteracts that. And then your body still thinks you're pregnant, because that was the point. Remember, when we looked at progesterone only, we had certain female cycle effects, which were not growing as much endometrium and which were not necessarily having a full period. We had certain male-like effects because progestins can be androgenic. And we had pregnancy mimicking effects because, yeah, that was the point of telling the body you're pregnant so you don't ovulate. Now you take those exactly as you learned them for progesterone and add estrogen. Now you build endometrial lining. Now you often have a placebo period. Now you increase the risk for a clot. Estrogen counteracts androgens to some extent. So you're going to have fewer androgenic effects of the pill, and you still think you're pregnant. So I like to do it this way so that I'm not memorizing a list of effects. So if I can just say things I know happen when you're pregnant, those are going to be side effects. Things I know happen when you have androgens, those could be side effects, right? So you're not memorizing different things for each topic. Okay. The main synthetic estrogens, which were on a previous, when we talked about the male and female hormones, we talked about biggest physiological hormone was estradiol, or E2. But the synthetic ones are ethinyl estradiol, EE, mestranol, estradiol valerate, and estrase. You're still going to almost always see ethinyl estradiol because that was the go-to. Why did we make a derivative of estradiol for an oral contraceptive? Why didn't we just use estradiol itself? Bioavailability, yes. Oral bioavailability. And you're thinking about that with all testosterone, all actual progesterone, all actual estrogen, the physiological ones, not orally bioavailable very well. So that's why you're seeing these synthetics. Estrogens, all of these are going to bind estrogen receptors and act as those growth promoters, which is why you saw that cancer risk. Estrogens can also increase sex hormone binding globulin. Your body is always releasing estrogens and progesterones to some level. You're never going to stop releasing those. Women's bodies always release testosterone to some level. Men's bodies always release estrogen to some level. Normally in women, the sex hormone binding globulin in the blood is going to grab up free androgens and reduce the androgen level. Normally, you don't have a lot of that globulin. So with no drugs around, you may be, say you're a teenager and you have women when they're in their teens are going to have a higher testosterone level. And so that's why they get a lot of acne. And so if you give a pill with estrogen, you just upregulate the globulins. And now those upregulated globulins are also going to bind the androgens that you're making. And then that's going to pull some of those androgens down and reduce the acne. The estrogen is very selective, so its effect is really on the availability of the androgen. All right, so your EMPs, they're all used the same way, except when they're not. Technically, you're looking at these and you're going 3 weeks on, 1 week off. That's called a 21-7. You can have the combined progestin and estrogen pills. You can have the transdermal patch, 3 weeks on, 1 week off. Vaginal rings. If you take a week off, will you have a menstrual period? Yes. If you don't take a week off, you can go on vacation. Ladies know what we mean. You don't want to have your period on vacation. That's not fine. So the combo contraceptives, we had drawn out the progestins. With the combos, we have estrogen as well. Earlier, we drew the progestins, and I'm going to try to draw it just like I drew it before. Except for now, at day 21, we're dropping everything, and the progestin drops. With the progestin only, we didn't want it to drop, right? But here, that's fine, because we also had estrogen being given, and the estrogen has a longer half-life, so it didn't drop as fast. So it still maintained that threshold that we needed. That's a simplistic way to explain it, but it's a way that works. You're just saying I have a threshold of hormonal concentrations before I don't have enough hormone and I ovulate. Progestin missing 1 or 2 pills is enough to go below that threshold. With a combo pill, the estrogen keeps us above the threshold, even on the placebo. That's why for the first 21 days, the estrogen's doing its thing, the progestin's doing its thing. And then when you have that placebo break, you do have a drop in both, but it's the progestin drop that causes the shedding and menstrual period. I'm not going to do anything but remind you that people concerned about cancer risk, prior use of combined OCs, I don't know about progestin only, but the study here was combined, showed these reductions in ovarian cancer and uterine cancer risks that lasted, here's 10 years after the pill. So that's pretty significant. Adding ingredients. Have you guys heard of like birth control pills that have iron in them? Fe means iron. Anything that is a pill that says it has Fe has iron in it. And if you look up FDA approval, it says these are present to facilitate ease of drug administration via a 28-day regimen, are non-hormonal, and do not serve any therapeutic purpose. So what they're saying is if you're on a 21/7, we're just putting these here as your placebo pills so you don't forget to take them and you don't lose track. But instead of giving you placebo, we're just going to put iron in them. Makes sense. If you're bleeding, maybe you need some extra iron. I graphed this out. I did the stats on how much iron the average woman loses during a menstrual period, how much iron is present in these 7 days. These pills do nothing. Take an iron pill. If you have low iron, go to the vitamin section. This has no purpose but marketing. They can say, hey, we got iron, but even so, they have to admit that it doesn't serve a therapeutic purpose and that the only reason it's there is ease of drug administration. If you make a birth control pill that has sparkles in it, they'll sell it to you. Okay, and the other thing that could be added is folate. What does folate do in terms of pregnancies? Does anyone just happen to know women who are going to get pregnant, or planning to get pregnant, or early in pregnancy are told take a folate supplement? Folate helps spinal column growth. You might have birth deformities like spina bifida if the fetus doesn't have enough folate. So that's why they say if you're trying to get pregnant, take folate. This was also a marketing thing because the only reason you want that folate is if you get pregnant, you're trying not to get pregnant. They say it's indicated for use by women who choose to use an oral contraceptive for contraception. It really doesn't tell you why you would want to raise folate levels. And in general, you wouldn't care if you're not going to get pregnant, but you'd be taking folate anyway if you were trying to get pregnant. So again, these two things, they're glitter. And this isn't enough folate to meet the needs anyway, just like we're talking about iron. Changing your cycle can also help change premenstrual dysphoric disorder. That is something that you may be considering when you're choosing birth control pills. We had said progestin only, you have to take every day. Estrogens, you can massage it to get a menstrual period if you want. We knew that kinetics really mattered in terms of missing days. Migraine can happen due to the drop in estrogen during the placebo period. Premenstrual dysphoric disorder also can happen because of the drop of estrogen. And I really want to make that point. It's a because of. So it's that estrogen drop. The longer it goes on and the farther it falls, the more your chance of getting migraine or PMDD. PMDD is a type of depression. It used to be called PMS, but this is actually to the point where it's a mood disorder. It is a type of clinical depression. Because it's happening because of the drop in estrogen, you can treat it with hormonal birth control as well as antidepressants. So the theory for using estrogen and birth control pills is that it's the drop in estrogen, the length and the amount of estrogen drop that's triggering the depression or triggering migraine. So basically, you can have pills that instead of having 21 days of EMP and 7 days of nothing, instead you can go, okay, let's make it 24 days of EMP and only 4 of nothing. If you can have a longer estrogen cycle, then you're not going to have that drop of estrogen as far or as long, and you may not have migraines or depression. So if you see a pill that has more than 21 days of estrogen in it, unless it's like a seasonal or something that's supposed to be taken consistently, if it's a combo pill and it's got more than 21 days of estrogen, it's probably going to help those. And so that's something I really want you to know, what those 3 different progestins are doing, what's it called? The way you take them is going to affect you physiologically.